Dr. George Ruza and Ella Kalam. And so this is a first for us, at least at Cosmetic Surgery Forum. And so we hope that it goes very well. But part of the reason that I wanted to do this was in order to share information about telemedicine, because it is something that is so very new to us all as dermatologists, and it's incredibly important that we learn about this and share information about it to get better with it, because otherwise we're all going to be sitting here dying for the next 2 to 3 months while we're not seeing patients. So I'm gonna, I think I'll start with, if it's okay with you, George, I'm gonna call in George, who is the past president of American Academy of Dermatology and has graciously offered to share some of his wisdom. So maybe a short, if you can give us a short 2 to 3 minute summary of status of telemedicine with AAD and where we are, and then we can segue from there.
Okay, so you know, the issue is that we have a lot of resources on the website. You know, CMS has relaxed a lot of the rules, and some of the insurers are starting to follow that, and some of the states are also relaxing their rules. Problem is, of course, it's all over the place. Nobody has yet figured out all the details, and so what we did on the AAD Telederm area and the COVID-19 portion of the website as well, with links back and forth, to try to put all the information in there for Telederm so that people can hopefully utilize it at this time to minimize seeing patients in the office or as much as possible. So that's really the Telederm part. There's a lot of other stuff that we have on there, and so I would just suggest you go there. There's a lot of things to help the practices survive, and information about all the support, the legislation, and lots of other components. But we're going to focus on Telederm right now, so I think I should have Dr. Kalami tell you the details, because she's more of an expert. I have not even seen one Telederm patient. I have one Telederm patient scheduled next Thursday, so I'm like neophyte in this area as well.
Don't worry, I think we all are neophytes. I think that other than, I think Dr. Kalam, who's been doing it for 2 years now, I think, and that's amazing. So I'd like to introduce Ella to everybody who's on here, and we've known each other for now 3 or 4 years, and not only is Dr. Kalam my dermatopathologist and an amazing one at that, but she's an innovative person who is a groundbreaker, and so she started her own telemedicine platform. I can tell you that this session is not about pressing or saying that one platform is better than another. There are several platforms out there. I actually don't use Dr. Kalam's. I use another one, but this is not about that. This is about making it so that people understand what is going on with telemedicine and updating them and figuring out solutions for it. So Dr. Kalam is going to start with a few minutes of talking and maybe screen sharing what codes might be best and some very quick tips on where to get information.
Absolutely, I'm happy to. Hi, everyone. Thank you for joining us. Before I start, I just wanted to make sure that I give Natasha a chance to get out of the way any kind of housekeeping announcements. Natasha, do you need to tell anybody anything?
Thank you. I appreciate that. We are very excited to have everybody in this conversation. It's obviously a topic that is very, very pressing right now. We wanted to just let you know that because we had so much interest, we have to change just a little bit the way that we sort of told you that you would be able to jump in. We're still going to have live discussion. That's important to us. But just wanted to point you to your screens, and 3 things I want to point out. One, that the viewing that we're doing here is actually being recorded, and we will share that link with everybody who's attending after the meeting is over. So don't worry about that. You can revisit if need be. 2, I wanted to let you know that at the bottom of your screen, there are a couple of ways that you can participate. 1, there's a question and answer button that you can click, which will allow you to type in a question that we can see. Obviously, we won't necessarily be able to get to it immediately, but it will allow the panelists to know what questions are coming up. We'll be able to address some of those by audio, just in stream of conversation. Others, we may type a response to you, so you can see that. The second way that you can ask questions is by the chat button that's at the bottom of your screen. That will allow you to speak to all of the panelists directly. That will not be seen by the entire listening audience. And they will try to address those questions as well as they go. So that's the second way that you can ask questions. And then third, we will actually have some times that we'll carve out and we'll specifically say that this is a Q&A. If you have a question at that time, there's a little button at the bottom of your screen that says raise your hand. If you do that, I will take them in order of how they come in, and I'll unmute you so that you can ask whatever questions you might have directly to the panelists and have a bit of a back and forth dialogue with them until we move on to the next question. So if you have any questions that come up, please feel free to use the chat function and I will jump in from there. But I think we are otherwise set. Thank you all for being here.
Great.
Thank you, Natasha.
Thank you so much, Natasha. I'm glad we got everybody on the same page. And yeah, please feel free to ask questions. This is a discussion, not a lecture. Our goal today is to be helpful. We really want to simplify things. We want to share any experience that we all have and help everybody through this craziness. So I'll start by showing you. I'm going to share my screen, and I will start with the AAD website, that that table that I have gotten, I don't know, 100 questions about over the last week or so, because I want to really simplify that. I think that is, although our intention was to be super helpful, and the AAD really did the best they could with that table, that is the best we can do. There are no guidelines, and the AAD cannot really tell you exactly what you can do for private payers because there is no information that is general. So they had to basically follow what Medicare has put out. So let's first simplify that table, and in the process answer some of the questions that we've actually gotten from you before we even started this forum. So I'm going to share my screen with all of you, and if you do not see it now, please let us know, but everybody should be seeing the AAD table on the Telemedicine Toolkit website. Super helpful, very, very well done with super short notice. I was so impressed that they got all this done very quickly. However, it did confuse a few things, as you know, and that was not the intention. The intention was to be helpful, and let's unscramble it a little bit. So let me start with this. Modifier 95. Yes, that is the modifier for, this is the most common question I've gotten over the last 3 weeks. Modifier 95 is indeed the modifier that we use for video or synchronous telemedicine services. However, it is a subset of the GT modifier. And someone actually asked this question. GT and 95 are practically equivalent modifiers. We, over the last 2 years, so I've been doing Teledorm for about 4 years. For the last 2 years, we've been billing insurance. So we have thousands of visits that we have billed insurance for, and I'm happy to share our experience, but remember, it's very state specific. So I'll be pretty general when I give you that information. Modifier GT is what we have used, not 95. 95 can only be appended to some CPT codes. And yes, I understand that everybody's using 95 and that the AAD says you use 95. It's a newer modifier, started in 2017, I think. And it is not as inclusive as GT. So I cannot tell you to use or not use 95. Knock yourself out. Absolutely use 95. It's about the same as GT, but the experience I have is with the GT modifier, and that is a modifier that gets paid in my experience for the last 2 years. GQ, and this is where you know that things started to fall apart with this table. So the GQ is not really a useful Medicare modifier. This is for asynchronous visits. This is what we append to all of the CPT codes when we do store and forward telemedicine. Medicare does not pay for store-and-forward medicine, telemedicine yet. And even during this crisis, using these codes, the CPT codes that we use for dermatology to try to get paid the same as we do for in-person visits, using GQ will not be useful. You want to use, in order to use these codes, you will have to do video visits. And I'll give you some tips about how you can do that very efficiently in a little bit. But moving through this table, for video calls, yes, these are the codes that you want to use, the 99201 to 215, that entire series, new versus return. And again, I use the GT modifier, which is more inclusive than 95, but they're practically the same. Not GQ, GT. And GQ, as you can see, really doesn't appear anywhere else in this table, but you will need it for private payers. The next forget about these codes, I'll explain in a second, so don't look at them. Build your regular CPT codes and your GT or 95, whichever you choose, modifier, their equivalent. Then moving to, these are private payers. Medicare, exactly the same. Use this table here to bill Medicare visits. But again, you need video calls. For asynchronous telemedicine, for private payers, absolutely use these same codes, not these other codes that are new. Again, I'll explain a little bit what they mean. Use the regular E&M codes that we have used for in-person visits with GT modifiers for synchronous video calls, and GQ modifier for asynchronous or store and forward. I hope that's clear. If not, we'll answer more questions. However, do not use the new Medicare codes. We do not have any experience using those codes. These 99421, 22, and 23 reimbursed half or less than in-person E&M codes. They are new as of January 2020. I have no experience with them. I don't think anybody does have any experience with these codes, and they pay very little. We will give everybody a reason to stop paying us. Telederm is even harder than in person. Often we spend sometimes more time, not less. So we do not want to get paid less, half or even less than half. So even though the AAD had to put these codes here because that is all we can do, that's what Medicare says you should do, and it makes this whole thing confusing. I really strongly recommend that we do not use these codes at all. And again, no one has any experience with this new set of 99421 to 23 codes.
Let's zoom in a little bit there, Ella.
Okay.
There are a couple of panelists that are wanting that. And then it's GT as in George Tom, correct?
Correct, yes.
GT. So yeah, thank you so much. That is great. And one question from a panelist was that of asynchronous. What is asynchronous versus synchronous?
Yes, synchronous teledermatology means video call. So it happens, you're talking to the patient live, it happens at the same time. So synchronous conversation. You're talking, the patient's talking back. We're doing synchronous teleconferencing right now. Asynchronous means you get a picture from multiple pictures from a patient and you send them back an evaluation. And that is a lot easier for most dermatologists because it's more flexible. More importantly, and I really want to make sure that I make this point, I don't know if all of you have seen my picture in that email that went out, but you can tell that I look better now than I do in that picture. You know why? Even though I'm older by, I don't know, 3 years. You know why? Because on video, everything is blurred out. The resolution is not great. You cannot do dermatology on video. You have to look at pictures. So even if you do choose to do mostly videos, and one of the participants asked this question before the forum, even if you do choose to just do video, please start with pictures for many reasons. One, it allows you the flexibility to know what you're going to be looking for. It allows you to actually make a diagnosis. Dermatology is perfectly suited to teledermatology because we look at pictures a lot. We diagnose things by looking at them. The pictures are high resolution, video is not. You can talk to a patient all you want. You can tell their mental status, but you're not going to be able to tell even if they have psoriasis or eczema. You know, you could be looking at their rash on video and still not know what they have. And you can make it a lot easier on you if you get pictures first. You can then use that to almost schedule that patient. You know what you're about to get into. So even if you want to do video, you can then schedule the patient just like you would in the clinic. So use that as almost the patient's calling the practice to make an appointment with you. And then you're going to be making that appointment, except the appointment's going to be a video call. You cannot do teledermatology with video only. I feel very strongly about that. And if anybody wants to contradict me, I'm happy to talk to them about it. But I really think that you have to start with pictures, or at least at some point get pictures of whatever you're trying to look at.
So thank you so much, Ella, Dr. Kalam. It really, that's a big help. We've had to welcome those who have joined here. We are about 10, 15 minutes into a conference that is just sharing tips, explaining the state of the art, and really just about everybody in this area has changed, in our field, has changed from being a standard dermatologist to being a teledermatologist almost overnight, which is insane. So, I mean, we're very, very happy to help anybody here that we can to make this a little bit more obvious. So having said that, we have a couple of questions that I'm going to ask them to you guys. And that is number one, what about Medicare if a patient can do voice only? They have no iPhone, etc.
So that is not telemedicine. You cannot bill the 99201 to 99215 codes for telephone encounters. What you can do store and forward and build these other codes that are brand new that I was going to talk about, and talk to the patient on the phone. You'll get paid a lot less. I don't think it's ideal, but phone does not qualify as teledermatology. It's a communication.
We are actually communicating with CMS about that, because there is a push to try to have them actually during the pandemic allow physicians to bill using just audio only. But at this point, that is not allowed. The other option you have, which isn't optimal, is you can use the virtual check-in, which pays you $11 or $12, which is the G code. That would be the other one that that's the one you can do for video only. I mean, sorry, audio only.
Audio only. They thought they were in this right here.
G2010.
Yep.
But again, it's probably not worth the trouble.
That's exactly the problem. And a couple of people were asking, why does it say GQ, but we're saying GT? It's just personal experience, is what Dr. Kalam is saying. That if
Not exactly. GQ is for asynchronous store and forward visits. GT is the same as 95. So use GT or 95 for synchronous or video visits. So all of your Medicare E&M codes, if you want to put a modifier next to them for telehealth, put GT or 95. Do not use GQ for Medicare. I know that that's what this table says here, but that is not correct. You will not get paid even during this crisis with that. However, Medicare, and let me show you what the Medicare Telemedicine Health Care Provider Fact Sheet that was issued March 17th said. Basically, they don't care if you even put any modifiers at all. Just see your patients. They will not audit you in any way. They are literally telling you that right here. All of the waivers, they will not conduct any audits. As of March 6th, if you wanted to conduct a video visit, you don't even have to put the GT or 95 modifier. They'll pay you. I do, because I want to keep track of how I've seen the patient. So I do put the GT modifier. Again, I use GT, not 95. You're welcome to use 95 if you want. I think it's less inclusive. It's a newer modifier and it's less inclusive. So up to you what you want to do with that. But GQ, you should not use for Medicare at all. If you're better off not putting a modifier on that E&M code right now in the emergency, because they tell us just they're going to pay you the same at the same rate as regular in-person visits.
Great. Let's open up to Brenda Dinteman. Natasha, can you unmute her, please?
She is unmuted.
Brenda, I don't see that she's unmuted. Brenda, can you talk?
Unmute myself, yes.
Okay.
Okay, thank you so much for doing this. This is amazing. I just wanted to give a little perspective from having used Store and Forward for over 8 years and now trying to blend it with video conferencing. In just this quick experience, Store and Forward is truly superior for diagnosing than video conferencing. We know that from the studies. We know that from Alice Armstrong. We know it from a lot of things. But what I'm seeing is there's a possibility of using Store and Forward, a very Store and Forward HIPAA compliant app, and then the doctor is able to review this very quickly and have an efficient teleconferencing call afterwards. I think what I'm hearing from my colleagues is there's a great frustration, of course, with technology, of course, with seeing the physical exam and trying to do a usual examination. So I'd just like to propose that there's a lot of mechanisms out there to do a HIPAA compliant Store and Forward consultation. They enter all the data just like they would, and they have the pictures there. You absorb that information, you absorb the history, you know exactly what it is before you even talk to them.
Yep.
And then you do a very efficient video conferencing and do whatever you do with the patient. You decide what it is, you tell them what it is, and then you prescribe. And I'm seeing that a blend of this is not only something that we need for now, but it's going to be lasting. And I think right now, because it's all been opened up to non-HIPAA compliant, that's great, but it's not going to be sustaining. And I'm sorry to talk so long, but I'm very passionate about this. But I think that as we return back to our lives, there's going to be a blend of in-person visits. And I think telemedicine will sustain, but it has to be blended with HIPAA compliant, very efficient telemedicine. And I think that's what's going to help the patients and what's going to help us get back on our feet.
I completely agree. I don't know if 100% of the visits are going to require a video call. So I'm not really sure I agree with that. And if you have so much experience with Store and Forward, I'm pretty sure you agree with that as well. It does make the call a lot more efficient, no question. And that's exactly what I was going to suggest. If you're going to slap something together, Zoom alone is not enough. Have a way to get the pictures, to do the Store and Forward part. Like you said, you already have all the information that you need, and you can have a 2-minute call so you can justify the synchronous, the video call billing for Medicare or any private payers that require that. So now I see some of the questions now that I had time to look at them. To repeat, for private payers, GQ modifier is what you're going to be using for Store and Forward. If you have even a brief video call, then definitely GT modifier. However, in any way that you're going to be seeing these patients, you have to have a way to send them an evaluation. If you're truly discussing all of it with them over a phone call, that will not be an efficient phone call. It'll be or it could be efficient, but it will not be short, right? So you will have a regular in-person visit with that patient over video. That's it. So even though you've looked at pictures and you spend time ahead of time, that video call has to be the same as an in-person visit, because you have to give all that information to the patient. I can give a lot more information to a patient when I send it to them through an evaluation that they have time to read, digest, ask me questions about. It's a completely different way to give information to the patient. You do have to give them an evaluation if you do store and forward, and it has to be thorough. Honestly, it's more thorough than in person. And I can show you some examples too, but we often get comments from patients, this was way better. I never got to ask so many questions of a doctor in person because I didn't have time. You can read them in a minute. It takes them 10 minutes to tell you all the stuff that you can read in a minute, right? So yes, if you're gonna slap something together and you wanna do Zoom, great, but figure out a way to get pictures and send the patient an evaluation, or spend the 15 minutes with the patient to explain what you found.
Great.
Another question that I saw here is, what about point of service, which I assume that just means what you use normally for an office visit, because you point of service is 11, you would be using 0, 2 for all of these. And one other minor item is that if you decide to do, especially during this time, do your video, the audio video synchronous teledermatology from your home outside your office, then at least for Medicare, they request that you add your home as another address for your with Medicare, so that it's like another side of work.
Excellent.
Is that even during this pandemic or during this crisis, or is that usually? Because
no, that's during the pandemic, because I don't believe you can do it from home. You're not supposed to do it from home, at least for Medicare.
so
Even the patient isn't supposed to be at home either. There's all these rules on that, depending on
Right.
what you're doing, and
Normally,
state rules.
that's true.
But for the pandemic, you are supposed to, you can do it from home. The physician's home can be the site, but you're supposed to register that with Medicare.
I will share that link with that I just showed everybody. I will share it with everybody. That is not the way I read it for these explanations, for these exceptions during the crisis. I think that's very possible that you have to still do it, especially since they specifically say they will not audit any of this. I think that's definitely a stretch of interpreting that paragraph. I don't want to contradict the president of the AD though, so do whatever he says.
It's okay. I'm the past president, so it's okay. But yeah, but anyway, that was from one of the announcements.
Okay.
Anyway, so in our office, we've actually registered all of our home addresses to Medicare.
So what happens then if you're speaking to grandma and she has no ability to connect via video, and you have a phone call? Are you able to bill a 99213? No.
No.
Not even under pandemic rules.
Correct. However, we've reached out to CMS to try to get that permission, but at this point we don't have that yet.
Because I will tell you, it's been a challenge, even for tech-savvy teenagers. So I'm going to say a few words about our experience so far, which is that we have had about 45, 50 visits now from telemed since we started doing it about a week ago or so. And of those 50 or so visits, probably 5 to 10 have been absolutely impossible. You know, we've been talking to people who've been in anything from their cars to their, to some place with zero reception, and it's been absolutely disastrous for them. The majority of people, we get some form of video. It might go in, might go out, but it just hasn't been efficient. That's the last thing. So what we've gone to is, and I think that Brenda and Ella have all said this. Send a picture before your visit. Show me a picture of the lesion that you want to have evaluated, of your face, for your follow-up, for your acne, etc. And the nurses get that in the chart, and then we start the process without having those pictures in hand. Sorry, my clock is going off for a second. So that helps a great deal. The other thing that we've gone to experimenting with is we happen to have some monitors in each room. We have a system called TouchMD, and we've enabled those monitors, which weren't really TouchMD monitors, they were just monitors, plain old monitors, to do a visit, and the nurses will work with the patients for about, usually it takes about 10 or 15 minutes to get the video set up. They'll get the video ready, and then I'll go into the room after they tell me the video is ready. So those are some points that we found have been helpful. I know we have a question from Ava Shambiam. Ava, if you're there, I'm going to unmute you and feel free to ask your question.
Okay, so in Los Angeles, it's very, can you hear me?
Yes.
Okay, so in Los Angeles, it's very, it's very onerous for people to come in for follow-up, like especially for acne visits and for Accutane visits. And so I've wanted to do telemedicine for a long time, because that way, it's onerous for the parents too. They've got to take off work, they've got to drive their kids in, they've got to park, and then coming into the waiting room and sitting in the waiting room, and then nobody really knows why the patient's there. I mean, I just think telemedicine is so important to change the way we deliver healthcare, because essentially we're still doing it the same way as we did in in the 50s. So I'm hoping, so the problem has been here in LA is that the insurers refuse to pay, and so we have this calamitous situation now. Yeah, right, Ella, I agree. So we have this calamitous situation now, and so now the insurance companies are paying the full amount, and I'm hoping that the AAD will, or at least all of us, that we make a big stink about it, so that after this is over, that we can still get reimbursed for these visits. I mean, it just makes the whole process of medical care so much better. And as you pointed out, people have an opportunity. They're sitting in the comfort of their home. They can submit their questions. It can be a much better visit for all. I mean, it just improves healthcare. So I really hope that this situation remains and that we get the full reimbursement, because we started billing for it. We did an app and we did the whole thing. And then our biller was like, you can't do this. It's illegal. You can only bill if people are 300 miles away and you're in Arkansas. So,
So I think your biller may be wrong about that. We certainly are billing lots of asynchronous.
Well, now,
No, we've been doing it for 2 years.
Really? Well, I don't know. I mean, that's what I was told. And we have I've got 2 offices. We got we got a lot of providers. So
Absolutely.
whatever.
There are tricks to it. It depends on the carrier. It depends on your contract. In California, you shouldn't have as many problems as I'm hearing you have, but certainly the same rules apply for prior auths. I know the rest of the country doesn't really understand our HMO craziness here, but it's a lot worse here than it is, I think, anywhere else. But prior auths still apply. All of the other rules for in-person still apply, but a lot of the private payers, honestly, with the exception of fairly recent, a few months ago, exception of Aetna, which now has only decided to reimburse one single teledorm provider. That's really been the only exception for private payers, PPOs for California. And otherwise, it really does depend on the state and on the carrier and on parity laws that each state has for private payer reimbursement for telehealth. And I will show you that in a little bit after we're done with some of the questions.
Okay, well, that didn't seem to be, obviously it's true now. And so we're seeing patients and we're billing,
So it is illegal in California for most private payers to not reimburse you on par with in-person visits.
Right,
California
yeah.
has a very robust parity law, and they cannot tell you that you cannot bill that the same exact way, and they're not paying you the same exact way that they're paying you for an in-person visit.
Right.
that
Well,
a new thing?
that's
Is that
certainly,
new?
that's certainly true now. That's certainly true now, obviously. But I
No,
don't know.
no, that's been true for, I think, 2 or 3 years in California. The law, the telehealth law includes a very robust parity provision that has made it illegal for private payers not to pay you. I will show you. I will show you in a little bit.
Well, Ella, we'll be in touch because that
Great.
was really not, that was not our
Say the
impression.
same thing to you.
I'm
Yes,
just hoping that this remains the
agree.
situation because it's
Yes.
much better.
And there was one other question. What about seeing people out of state? Is that a state-by-state thing? So for example, if your patient lives in Nebraska normally, but they are vacationing in Arizona, what are the laws on that?
That is a great question and a matter of great controversy, even among those of us who do a lot of telederm. So if you see a patient in California who's traveling from Florida and they come to your, in Nebraska, you're in Nebraska, someone comes from Florida and you see them in Florida, they have an insurance in Florida, does anybody tell you you can't see that patient?
No.
Just because they live in Florida?
Right,
No.
right.
So a lot of people are interpreting seeing a patient who lives in Florida but is currently on vacation in Nebraska as it's a question. What kind of patient is that? Is that a Florida patient or a Nebraska patient? To me, is wherever their residence is. And with college students, it's even more difficult. We run into this all the time. I have 37 state licenses, so it's not as much of an issue for me. But when one of the other providers on our platform has an Accutane patient that moves for a month for an away rotation, they refuse to do their Accutane follow-up because the patient's no longer in their state, even though the patient is a resident of that state. And I do not tell them what to do. I think it's a matter of controversy. I've not been able to read anywhere how you're supposed to really do that. So we just transfer it to someone who has a license in the state that the patient is in.
George, do you have any insight into that?
I wanted to comment on that. So, and it depends on state rules. So each state has its own rules on what works and what doesn't. But in general, you have to have a license in the state where the patient is currently physically, not where they're resident or where they have their summer home or whatever, wherever they happen to be that moment. That is the state you should have the license in. However, for this epidemic, CMS has relaxed those rules so that for Medicare patients, they say, oh, patient can be in any state. You can be in California, patient can be in Nebraska, and that's totally fine for Medicare. However, most states will not allow it. Some states will, some won't. So that's where you get the difficulty. Because even if you do it for Medicare, you still are not legally following what your state does for your license, so you really can't.
Totally. And be super careful about malpractice. So even if Medicare, and let's say all states will tell you totally fine, remember that your malpractice may not be covering you to practice medicine in a state you're not licensed in. So I think this is going to open a huge malpractice issue. So even if all the rules get relaxed during this crisis, be super careful about what your exposure is. I can't imagine that, you'll get sued for trying to help, but just be cautious, because malpractice is another issue that could be a problem if you practice in a state you're not licensed in.
Great. And we have Deidre Hooper.
Hey guys, can you hear me?
Yes.
Yeah, thank you so much. This is incredibly helpful. So I really appreciate it. I had my first Doxy.me patient today. And my first question is, how do you prove that you had a video chat with the patient?
So I actually take a picture with my iPad through Nextech of the actual visit. I've asked my PAs, we have 2 PAs, and when they see people, they also take a picture, just a simple picture in it. I think that helps at least a little bit. What do you guys think?
Why would you need to have a proof? I mean, what kind of proof do you have when a patient comes in person?
I guess I'm questioning the difference between the GT code and the GQ code, that if you do photos and it's store and forward, it's different than if you did live video. And I think I heard you saying that if you do live video is the way that you can charge the 99212s that we normally charge or whatever in practice.
That's just for Medicare. So you can charge the same codes for the GQ or the store and forward modifier for private payers. There are some states where they will not pay you for anything that's not video, just like Medicare does. But for Medicare, yes, you have to do video. And you're right. I do think I am uncomfortable not having proof that I talked to the patient. So the platform that we use definitely keeps track of that and automatically records the fact that you did the video and for how long.
And I'm just going to go through a couple of questions. I think that most of them have been answered. Joyce Davis asked, I want to know if you can bill for seeing pictures, discussing care and prescribing, but no video. And the answer is yes, but it's a different code. That's the asynchronous code. Okay.
The GQ asynchronous code, and the answer is yes.
Correct. What are HIPAA, Dr. Andrew Trowers, what are HIPAA compliant ways for patients to send images prior to their visit? Any ideas on that one?
So multiple platforms, obviously. Your EMR, many EMRs have either slapped together a solution for Telederm or have had kind of a solution for Telederm that no one's been using. Their email's not it. So yes, you don't have to worry as much about HIPAA during this crisis, but if you're gonna do Telederm, and I'm guessing a lot of people are gonna, if you do it right, you're gonna love it. I can tell you that for sure. And patients are gonna love it too. And if you do it and you like it, you're not gonna be able to sustain any kind of non-HIPAA compliant communication after this. So, you know, don't rush to do that. I mean, this is, you know, a time where you wanna preserve your revenue the best you can and do something as quickly as you can. And there are some, you know, places that you can join that will allow you to do that. But whatever, if you're slapping together Zoom and email, that's not gonna fly in a few months.
And that's a great, George?
Well, no, I had a follow-up on something that I just got Mark Kaufman send me a clarification and why we have the little bit of a disagreement on the address, whether you need your home address registered with Medicare. It looks like they initially did, but now apparently they are modifying that, and there's more clarification coming. So you may not during the emergency have to actually.
I agree.
Yeah,
That's from AMA's. I just got that from the AMA website. So very
excellent.
good.
Thank you.
Glad we got that.
Thank you. And I think that Brenda Lukowski had a question. How are we getting patients to convert? Many of our patients decline and say, "Oh, come see us later." Well, you know, that is a good point. There's a lot of pain that is out there, and people are paying for these visits, and maybe they don't see the value of it. Can we unmute Brenda? Brenda, are you on? Can we try to unmute her so she can explain what she's having issues with on the conversion as well?
She's unmuted on my end and just needs to unmute herself.
Great, thank you. Brenda, you're on.
Bottom left hand, there's a little microphone that you can click.
Okay.
Might want to move on for the moment.
What I'm going to say is that we have talked to our patients, and one of our payers, Blue Cross of Nebraska, has amazingly said that they are willing to pay for entire visit, zero deductible, zero copay, so they could have a $10 million deductible and they're going to pay for it. At least that's my interpretation for telemedicine during the crisis until a certain time. So that's a huge gift. Aetna is also doing some things with paying for the visits. UHC, not at all. UHC is giving us nothing. and several other payers, the smaller payers are not. So what we're trying to do is to explain to people that there are certain payers. If for those of you who have a decent EMR system, you should be able to take your insurance payer patients and separate them, and then send a note out to them, an email out to them saying you can go ahead and make an appointment and pay nothing for it, and we'll be happy to see you. So we did this for both Aetna and for Blue Cross. Now, the problem with Blue Cross for us, at least in our situation, is that Blue Cross lumps everybody in. So Blue Cross could mean Blue Cross of Nebraska, Minnesota, New York, and it's only Nebraska that's doing it. So be careful about that when you say it. Always make sure that you have the individual payers. I think, Brenda, you're on right now. Can you hear us? Brenda? Nope. Okay. Next question, Brenda Dinteman. I had a question if we can unmute her again, Natasha.
Hi, I'm here. I don't remember which question I had. What were you referring to?
Something about the acne.
Oh, just reinforcing what she said about acne treatment in the LA world. It is incredibly efficient to do store and forward follow-up acne, very HIPAA compliant for acne patients. And that is something I think we should push for. I think you get better compliance, you get better resolution, and the communication back and forth is very rewarding. You actually give them more details, I think, than you do that they retain when you do it through store and forward. So it's just another push for store and forward being very helpful in certain situations. We know it's helpful in psoriasis with people on biologics. They've done equivalent studies, not superiority, but equivalent studies showing that it's as helpful to do a follow-up for a psoriasis patient or an eczema patient on a biologic as it is to see them in person. And sometimes you get better compliance. They show up and they comply.
Thank you. We also Heidi Anderson asked for clarification on UHC not reimbursing. So UHC is reimbursing, but they're not doing what Blue Cross is doing in our state, which is if you have a $10,000 deductible and you have a visit that costs you $150, they're going to charge you $150. With our insurance, with our Blue Cross, and potentially with our Aetna, they're paying the full thing. There's a question about malpractice. I'm not sure if Joe Perlman is still on, but Joe Perlman had asked, our malpractice carrier ProAssurance has made a sign that we will not see a patient that is in another state. Our license ID to practice is in this state. We can see resident of any state in our office because we're practicing in state with our license. Maybe, Joe, can you unmute her? Because I'm not sure I understand quite what the question is.
Joe is unmuted on my end.
I'm not sure if you if she's on, but we'll unmute you if you do. If you are on, please ask that. Adam Luber, legally speaking, how important is having an MA in your visit as a witness, in your opinion? In mine, I don't think it's that important. We don't have anybody. I've done a couple from my house where somebody's off, one of my nurses is off site and answering it. I don't know, Ella or George, do you have any thoughts?
And there is no need, no requirement. The only requirement is that you, as the physician and provider, are there at the visit. There's
Absolutely. I assume this is for video, right? Because for store and forward, you're giving them a lot of information, and there's a very obvious record of a really thorough evaluation and a lot of back and forth and chatting. Even we have MA support, and there's, clearly chatting between the patient and the MA, and also the doctor and the MA. So I'm assuming this is for video, and I'm not aware of any requirement or liability that you would incur if you do not have an MA.
Right.
Great. I think Cheryl Citron, can we unmute Cheryl? I think
I'm here. My question is, like I started today, I have Emma, and they just released it yesterday, and I had about 10 patients today, and I share your pain. It was a lot of aggravation with trying to explain, and especially with the older patients. Now, if I've made the appointment, the patient's on the phone. I mean, I've got the whole thing. I'm waiting for them to connect. I'm calling them because they can't connect. They can't download the app. They can't get on the patient pop app. They don't remember the password. It's going on for 10 minutes. Finally, I said, forget it. Just send me a picture. They send me a picture. I respond on the phone, blah, blah, blah. I actually cannot bill a 99213 for that, correct? It has to be that stupid GQ because it technically was not synchronous.
Correct. It's actually not even a GQ unless you communicated with the patient and they had access to you to ask you questions through an electronic means, and you were able to respond to them. So it's not even that. It's a telephone.
No, I did. I was on the phone. I called them back. I looked at the pictures, called back.
Yet. Phone does not count yet, to my knowledge.
Okay, so then don't even bother to bill that.
Well, you can bill, but I think you make $11 or something like that.
And my other thing was about the HIPAA compliant sending of pictures. Like, I think you brought that up. Don't worry about it for now, but we need a HIPAA compliant platform to send photos, because they're just sending me, on my message on my phone.
Yeah, that's a problem for most EMRs right now. They're just doing the best they can to slap something together. You may want to consider looking at, other options.
Thank you.
Great. Joe, are you on? Can you talk? Joe Perlman? I think you may have to unmute your lower left-hand corner also. Okay. I think we can. Natasha, is Joe unmuted also?
On my end, yes.
Okay.
Try again.
While she's trying to get that working, we have another, is Brooke Satish on? Can we unmute there? Brooke?
Unmuted on my end.
Okay. Brooke wants to know, how are people collecting payment for visit, regular copay, deductible? So my answer to that is that we're doing a variety of things for that, a huge variety of things. We collect some people's insurances beforehand, but we are essentially screening everybody beforehand. Natasha? Hello?
Yes.
I think, Natasha, you're still on the screen, if you can.
My video is off.
Okay. So, George, are you still there?
Yes, I am.
Okay, great. So, what do you recommend that we do on this? Do you have any thoughts?
Well, and I kind of actually answered that in one of those type questions. So, at least I think you should you have to establish what the situation is with the specific insurer first, so that you know, and then we collect the copay or whatever we would normally collect from patients who comes into the office. We collect it at the time of the visit. So in this case, we actually collect it at the time they make their appointment, whatever the copay or co-insurance or whatever we estimate it will be.
We do the same. We have an eligibility checker, and their insurance gets, just like when they come in to the front and we check it, we figure out their copay, that's what gets charged to their credit card. And then the visit gets submitted to the insurance, and the balance gets billed just like in person. And speaking of just like in person, I really feel very strongly, and I think one of the reasons that Telederm has gotten a bad rap over the last 10 years is because people cut corners. And I really feel very, very strongly that Telederm should be no different than in person. If you cannot provide the same care, crisis or not, yeah, in a crisis, maybe you're gonna see the patient later, but in general, if you cannot provide the same care, quality care that you would provide in person, that is not an appropriate telederm visit. So for example, if someone comes in and you look at a lesion and you literally don't know what it is, that is an in-person visit. You have to reject that visit and tell that patient they need to be seen. Actually, Joel, you just had someone like that just a couple of days ago with a KA. You saw the patient on telederm. Clearly that needed a biopsy. That is why we're doing telederm in this crisis, to find out what's not appropriate for non-urgent and for telederm. Then you bring them in. When there's no crisis, that should be the case too. If the patient submits a visit on telederm and you cannot do what you normally would do next if you saw them face to face, that is not appropriate for telederm. And because of all of these get rich quick, let me make as much money as I can, you know, the type of schemes that telederm, there's so many platforms that do this, that's not appropriate. Never has been, never will be. And it shouldn't be in a crisis, it shouldn't be after the crisis. And that's the reason that the AD had to come up with a statement that said they're not even okay with store and forward, because everybody was trying to pay doctors $10 a visit. And for $10, you can only give them a one-liner back, right? You should not be doing that ever. If you can't take care of patients the same way as you do in person, don't do it. It's bad medicine.
Is Monica Rani on right now? Let's try and unmute her. She had a couple of questions, and then I'm gonna wrap it up with a couple of suggestions that I have. Monica, are you unmuted?
Hi, Joel. Can you hear me?
Yes, perfect.
Oh, great. Thank you again, guys, for doing this. This is great. I was responding to one of the comments earlier, first thing, that I was using a Clara messaging system, which is secure, and they just added a video option. So that was kind of an alternative to Doxy.me. And I think a lot of derm offices have that. You clarified a couple of my other questions, but my last one was for Medicare. Ella, were you saying that we would just bill them a normal E&M visit, and then if it was a video visit, we would add a GT as in Tom modifier? And if it was just a store forward visit, your recommendation is to not do the GQ and just bill it normally during the pandemic. Did I get that right?
The other way.
Mostly, but you cannot do, you really cannot do store and forward for Medicare. Even in the pandemic, they said that they want video. Now, they will not audit you, but I will not recommend that you do that. Any Medicare patient that we have, we do video. So, and what they did say is, we don't care if you put the modifier or not. I do put the GT modifier for video. 95 or GT, same thing. Again, 95 or GT are the same. I do put that modifier on because I want to keep track of how I saw the patient. But Medicare said that you don't have to. They don't care. They won't audit you, but you still have to do a video. So again, my recommendation for that is that you do store and forward type visit. You evaluate everything based on the pictures, and then you have a brief video call and tell the patient, I sent you the evaluation. I just wanted to make sure we touch base and you know exactly what we were doing, and spend 2 minutes on the phone with them. You were super efficient. The patient got 3 times more information than normally they would in person. And it's a video call visit that's probably gonna fly. I gotta admit that none of my calls last 2 minutes. I am one of those doctors that
yeah,
so
me
if
too.
you know how to do that, great. But you should know that as soon as you engage the patient, they're so happy to see me in a crisis too. They're like, oh my God, it's so nice to see you. So I can't get off the phone in 2 minutes. But if you can't, off the video call in 2 minutes. But if you can, that would be the perfect way to do it.
Okay,
Even though
but
I do have to say that that's a bit of a concern, because at least the way Medicare looks at these visits, it's supposed to be similar to an in-person visit. So the time and what you do and what you document, you have to do, your little bit of review of systems and HPI and all that stuff. But the idea is it's supposed to be done during that visit. So store and forward piece kind of is difficult to see how they would relate, that they say, well, you did store and forward maybe even a day before. At least make sure it's done the same day, I would say. So that at least... I
agree, and I can show you how it's done. It's more thorough, not less thorough. You can get way more information from the patient and relay way more information to the patient back. And the phone call, yes, in general, for me, lasts longer than 2 minutes anyway. So for me, it's not an issue. But if you can get it done in 2 minutes, I think it's okay. I do agree with your comment in general. But during this crisis, I think that you can probably do that. After this crisis, I do agree completely with what you just said. And the phone call needs to be your visit.
Couple
Okay.
things on the
Thank you so much.
on the videos. What we've in many cases gone to doing is FaceTime with our patients. So in other words, we have a lot of FaceTime, a lot of clients that have Apple phones, and you can do FaceTime. Now the problem is that nobody in our office, not a single one of our employees, has a Samsung or a Droid phone. So we don't have the ability looking into Google Duo, but it's not been as easy. Any hints on that?
I think most people who have been using video not part of a platform, again, you need to figure out a way to get pictures that's not related, but most people have been using Zoom or Doxy.me, and those are great ways to do it. They do not in any way do anything except allow you to do the video call.
Got it. I know Thomas Vaughn has been wanting to ask a question. Is Thomas Vaughn still on?
I am. Actually, this is Keith Vaughn from Washington State. Hi.
Great. Keith. Hi, Keith.
Hey. So I asked several questions, but I mean, I'm not sure what Natasha unmuted me for. I mean, I'm not sure which one of those, because I asked several, and y'all have been given a lot of good information, so I appreciate that.
Well, any thoughts you have that you'd like to share or questions?
Well, all right. I want to ask, because again, a lot of my patients up here do not have they're either not savvy, or because of the current pandemic, they are keeping their distance. But I'm wondering if there's a way we can grab that phone visit and make it an asynchronous visit by maybe in the next day or two, getting a niece or nephew of one of these older patients to send a picture so that we can capture phone visits that I spent a lot of time on and I should get paid for. And I'm really thanking Dr. Harusa for anything that the American Academy of Dermatology can do to get
Yes.
board-certified dermatologists reimbursed for high-quality phone visits.
Am I still unmuted?
Yes.
Okay.
Who's
Okay.
that?
So my experience has been with my Medicare patients is that go ahead and do the video conferencing experience, and they are pretty comfortable with sending a picture to you. And again, I'm very into HIPAA compliant, but at this time, they send it to your email, or they send it whatever upload you have to your, but most of my patients don't seem to be able to do well with their patient portal on my EMR. So I have the consultation with them, I document, I ask the usual questions, we come to agreement on the treatment plan, but I do review, like you said, almost asynchronous, but the pictures. But I think the detail about synchronous is that you are face-to-face.
Correct. It
That's
cannot be a phone call. So
Do you
to
agree?
answer, absolutely. The phone call still doesn't fly, even though the AD is really, really working hard to get that to
It's
be.
the face-to-face. So do your face-to-face conferencing.
Yes.
But of course, you may have to gather details later, just like we gather labs, just like we gather a biopsy report from another doctor. We upload that. But just remember the part about the face-to-face.
Am I still unmuted?
Yes.
Hey, all right, so this has happened a couple of times where I've been on a platform like a Zoom or a Blue Stream or something like that. And so I make a connection, and so maybe that's lasting for less than a minute, and then it's just not going well. I mean, it's becoming problematic. Can I stop that, call them on the phone, finish the visit, and get paid as like it was a synchronous visit?
That's great.
I'll let you take this, Dr. Harusa. Technically, the answer to that is no. But during this crisis, I think you can probably get away with that.
I'm going to get away with it.
And then Adam Luber also had mentioned, how do you hide your phone number when you have FaceTime? time. We figured that out somehow on our iPad because you don't want to give every patient your phone number. But there's a setting on your iPad, and that you can do it just by putting in an email address, I think. Do you know that answer, Ella?
You really can't very well. You can, for most people, you can use your iCloud account that you never use for anything else, is another answer, and then use, just don't give them your phone number. But maybe, slap something together now and then have a longer term solution where you don't have to worry about these things. So look into better options. Yes, you want to really preserve your revenue, do something quickly for the next, last couple of weeks and the next few weeks, but just look into better options. There are better options that will make this pleasant. So, yeah.
And I want to probably close up with a couple of things that I want to share with everybody, and that is that we are going into this absolutely scary time for a lot of us. A lot of us have seen our revenues decrease to nothing, or maybe 5% or 10% if we can manage to see a few telemedicine patients. So I feel like we have been able to get about 5 to 20 telemedicine patients seen during a day, which is a little bit, but there are other ways. There are other ways that we can reserve or preserve our revenue, and that is, number one, look to everything that is in your clinic and analyze everything that is going out the door. For example, see if you're delivering a newspaper to your clinic, cut it off. You're not seeing patients anymore. If you have a person that's set to clean the windows of your clinic, stop them. You're not going to need clean windows for another 3 months. If you have the person who's cutting the lawn coming every week, maybe stretch it out to every 2 weeks. Any services that you have, like if you have Real Self, call them up and tell them you're not going to be using Real Self for a month because literally they cannot come in, and they'll usually waive that revenue. If you're advertising on radio or TV, cut it off. They understand. So there's a lot of things that you should be looking at in your clinic for the next 2 to 3 months that you do not need to be paying for. Be very careful, be very absolutely brutal in cutting any expenses that you don't need to pay, and that will help you to conserve your money during these tough months. Any other hints that you or George have on that?
Well, we actually, there's also at this point a lot of federal and state support for our practices, and that I think you should explore and take advantage of. We now have 3 pieces of legislation. The third one will be passed tomorrow, probably in the House, and signed by the president. But we've got expanded small business loans and Corona One. By the way, this is all on our website. We're putting that updating practical information that you can use. The coronavirus 2, the 2-week and 12-week paid sick leave, where you pay the sick leave, and then the government gives you 100% dollar for dollar tax credit on your payroll tax, and it's refundable. It goes over that, and there's specific requirements for that. It's related to COVID-19. And then this third one, which of course is still not yet law, but that has some huge benefits, because there are going to be some significant loans that the government will make for your payroll, but even utilities and all your other expenses, rent and so forth, which then if you use for certain qualified expenses is actually forgiven. So even though it's a loan, you actually is going to be forgiven for several months. And then there are some also tax credits for loss of business. So if you're more than a 50% drop in your business, which you just referred to, 5 or 10%, there are tax credits as well. So there's a lot coming up there. We have the first 2 laws. We do have the practical information there. The second one, which has the sick leave, takes effect April 2nd. The regulations haven't yet been finalized, but we'll be putting those up as soon as they are, so that you know how to take advantage of it. I know in our state, in Missouri, they actually have changed the unemployment thing. So if you have to lay off your employees, they pay you, they get unemployment but it's not counted against you, so they don't raise your unemployment tax going forward, for example. And that's the case in many states. So there's a lot of these other opportunities you should take full advantage of. It's a very challenging time.
Speaking of resources, I do want to, in closing, before we finish the call, share a resource that is very valuable and has been very valuable to us while we're trying to navigate all of the rules of Telederm in multiple states. This is a free resource that the government publishes and updates very frequently. I'm going to share my screen again so you can all see that. And get the link. This is the Center for Connected Health Policy. The AAD, I think, uses this also to track changes in legislation for each state. It's very, it's not complete, nothing ever is, so definitely still check with the board, the medical board in your state, definitely still check with the private payers. Each individual contract may be different, but this really has all the information that you need. You can, on this website, you can actually look by state at the different regulations. You can click on the state that you want to have more information about. You can then, you know, click on any one of these links. For example, for California, we talked earlier briefly about parity laws. You can read more about that, and it literally gives you the policies, the state laws and policies that are in place in that state. In California, we already talked about what they are. There is a really good PDF that you can download that is, I don't even know how many hundreds of pages. This is page 14 out of those many hundreds of pages that really summarizes where Telederm is right now. These things change monthly almost. So this number, Medicaid programs that reimburse for store and forward, used to be 11 just in May of last year. I looked at a lecture that I gave on Telederm, and this was 11. Now, as of last fall, it's 14. So every month, every year for sure, these get updated. And now 50 states and DC reimburse for live video. And finally, the comment I want to make is be careful interpreting these outside of Medicaid policy only. So all of these trends and policy statements really refer to Medicaid and Medicare. A lot of private payers have different rules. Different states have different rules. The parity laws we talked about force private payers in some states to pay you the same exact amount as you do get paid for in-person visits. So check with that in your state. Use this as a starting point, as a very reliable and up-to-date resource. Go to the medical board after that to find out if there is any more information that you need to know, and talk to the payers, or just bill a visit or two and see what happens if you're not sure or you can't get anybody on the phone.
And one point that came through from Brooke Jackson, which was excellent on how to save money, talk to your lease, your laser lease company about stopping the lease. Stop all withdrawals from your automatic withdrawals from your bank account. You know, you have tons of these things that are you don't even know what they are. Stop them for now. They'll have to come back to you to get it. And potentially talk to your landlord about the possibility of forbearing your rent. George, can you clarify? So my understanding, I didn't know how this money came back. So if we have a person who takes the leave, the FMLA leave, it comes back in your deductions?
It's a dollar for dollar tax credit that is applied to your payroll tax. And if your payroll, but of course, these rules have not yet come out, so the mechanics of it, I don't yet know. But it's going to be a dollar for dollar. When you're doing the 12-week one, it's a $200 a day maximum. When you're doing the 2-week one, which is more different requirements, it's a $500 a day maximum. And then you get a tax credit on your future payroll taxes, the 7.5% that you pay to the government from the employer side. And if your payroll tax is not enough because you've laid off all these employees, or your employees are out, then you actually it's supposed to be a refundable tax credit. There was a question here about whether physicians are included. Yes, physicians are included. They're included as part of the small business employees under 500, and they also included in the specifically mentioned in the part which deals with the credit for loss of business. So they're both there. Oh, I forgot. There was something else I wanted to comment on, but okay, I forgot. There was another item. Oh, yeah, yes, that wonderful site, the 50 states, all the details. So if you can also get to it if you don't remember the site at the AD website under the Telederm site or the COVID-19 portion, the Telederm site, it will take you right to this the organization that tells you how all the different states are. However, I have to tell you, it's updated, but the information is changing daily. And so when I went on there to look up what's going on in Missouri and Illinois, it wasn't quite up to date because it changes daily. So
they're trying, and they have COVID. Yeah. Yes, they're doing their best, but it's amazingly good for a governmental site.
I agree. It's very good.
A lot of people are asking whether the session is recorded. Yes, it is recorded. It's live on Facebook to the Cosmetic Surgery Forum site, so I'm assuming that it will be on that site. We will also distribute it to all attendees and probably through the CSF site. And we are just absolutely delighted that you could attend. We are really appreciative and incredibly lucky to have George Haruza and Ella Kalam here to talk about this, and really to have all of you out there who have taken your time to be a part of this. We will absolutely want to hold more of these over time to make sure that we are fully informed, because we're going to learn more, and dermatology has always been on the forefront of everything in medicine. And when there have been tough times in medicine, dermatology has always come forward with innovative solutions. And I'm absolutely certain that this is going to be one of those things. Those of you who have not started telemedicine, I think you're going to want to. Those of you who have started it, you're on the cusp of a movement, and we're going to make it better. We're going to innovate and lay the groundwork for the future dermatologists and the future of telemedicine. So be proud of yourselves and go forth and figure out what we're doing. Have a great evening. Thank you so much, George. Thank you, Ella. And thank you, Natasha, as always, for everything. Thank you.
Thank you.
Great. Thank you.
Thank you all so much.
Take care.
Take care.
Bye.